Hi, everybody. So thank you for coming to the first presentation on pharmacotherapy today. So I have the pleasure to introduce you to one colleague of mine, Dominique Elie. So which we were colleagues at some point. Dominique Elie is a geriatric psychiatrist who completed both her psychiatry residency and geriatric psychiatry subspecialty training at McGill University, and she recently joined the geriatric psychiatry service of Montreal Mental Health University Institute, where she works primarily in outpatient clinics. So she's also a clinical assistant professor at the Department of Psychiatry at the University of Montreal. But prior medical school, Dr. Elie completed a master's in pharmacology and worked on the pharmacological treatments in delirium and advanced cancer. Throughout her residency and subspecialty training, she remained actively involved in research and published several papers on psychopharmacology in the elder and medically ill. Over the years, she had provided psychiatric consultation services in many different settings, including geriatrics, intensive care, oncology, and palliative care units, physical rehab, and long-term care. As you can see, she is a quite rounded professional, so I'm very glad that she is here to present us on psychotropic med in palliative care. Thank you very much.
Good morning, everyone. I hope you're enjoying your time this week in Montreal, for those of you who are not from here. So we have roughly half an hour together to go over psychotropics medications in palliative care. I'll do my best to be fast enough to cover everything, but hopefully we'll have enough time for questions towards the end. So just to mention that I do have a potential conflict of interest that is not a real conflict of interest. And also to mention that throughout the presentation, I'm going to mention several medications that are actually pretty much not, indicated for palliative care use. So most of them are actually off-label use. So at the end of the presentation, you should be able to choose proper management for chronic psychotropic medications in the end of life, identify prescription strategies for tapers and increases for common psychotropic medications, and recognize medication interactions between psychotropics medications and common medications used in palliative care contexts. So during the presentation, we're going to cover mostly two CanMed's competencies, which are medical expert mainly, and also collaborator. So let's move on to the first objective. So being able to choose proper management for chronic psychotropic medications in the end of life. So basically, this is to cover what you should do when you have a patient who's been on psychotropic meds for a very long time, such as a patient with schizophrenia or major depressive disorder, like for several years. So if we start with antipsychotics, antipsychotics are not just used for the treatment of schizophrenia. They can be used also to augment antidepressant, and also they can be used in the treatment of dementia for behavioral disturbances, same thing in neurodevelopmental disorders, and as you probably know, in the treatment of delirium. So if you see a patient with an antipsychotic on their medication list, you have to think, maybe it's not just schizophrenia, maybe there's something else that actually, that was the main reason why an antipsychotic was prescribed initially. The antipsychotics that you can probably see in your patient's list in 2022, we still use some of the first generation antipsychotics, such as Haldol. Mostly your older patients can actually be on pretty funny medications that you don't think is still used nowadays, but it still happens. So Haldol, Loxapine, but I would say that the younger patients will mostly be on, and I'm sorry, I don't have a pointer. That would be easier for you to point on my slides, but mostly you'll see patients on second generation antipsychotics such as olanzapine, risperidone, quetiapine, and also clozapine. Clozapine, that I'm assuming most of you are not very familiar with, because it's really an antipsychotic that mostly psychiatrists will prescribe. So we'll go over that specific antipsychotic together for you to know what you should do exactly when you have a patient on that antipsychotic. So what should you do if you have a patient on antipsychotics? So first of all is to clarify the diagnosis, or why was this medication prescribed in the first place. The reason is sometimes patients can be treatment refractory, and it may have been very difficult to find a good antipsychotic to properly control the psychotic symptoms. So you don't want to rock the boat by, either decreasing or modifying the treatment. So first of all, try to clarify the diagnosis. And the next step would be to assess for side effects, because especially towards the end of life, many physiological changes may actually lead to more prominent side effects. So the most frequent antipsychotic side effects that you may encounter are actually extrapyramidal symptoms, such as Parkinsonism. Dysphagia is actually one that is, I think, important to remember, because often you're going to, your patients towards the end of life, they may have trouble swallowing. But keep in mind that high-dose antipsychotics, especially like Haldol, haloperidol, risperidone, they tend to cause some swallowing issues as well and lead to aspiration pneumonia. So this is something to keep in mind. I mentioned metabolic symptoms such as high glucose, especially if you have patients on corticosteroids as well. So this is something to keep in mind. Anticholinergic symptoms that can lead to constipation, urinary retention, and confusion, because with all the other meds that are used in palliative care, this can lead to complications. Cardiovascular symptoms, QTc prolongation, orthostatic hypotension, and to mention also neurological symptoms such as seizures. If you have a patient with brain mets or a brain tumor, they are at a higher risk of seizures, but keep in mind that antipsychotics actually decrease the seizure threshold. And as I mentioned, be aware that if you taper or discontinue medication, this can lead to psychotic or affective decompensation or behavioral disturbance, and I'm sure you don't want to deal with that on your palliative care unit or as an outpatient basis. So if you have a patient on antipsychotics that can no longer swallow pills, here I mentioned to consult the pharmacists in your team and psychiatry, because depending on where you practice, it's really country dependent. Formulations of antipsychotics are not all the same, so some may be available as a liquid form, but in a different country it may be something different. So to be honest, pharmacists are really your best friends when it comes to changing to a different formulation. So you have a list here. Of course, I would say haloperidol is probably your best friend, because you're going to be able to give this medication through different routes, of course, but we have other options with the other meds as well. So let's spend some time on clozapine now, because I think it can be very tricky, especially in palliative care contexts. So clozapine is special in the sense that it may cause a rare but potentially serious side effects, which is agranulocytosis. So patient has to have regular CBC monitoring when they are on this medication. And as you can imagine, if a patient is also on chemotherapy, this can lead to really what we call a code red, so that the white blood cells are pretty low. And when it happens, you have to stop clozapine for some time and involve hematology to see if the patient's going to be able to reintroduce clozapine. So here I mentioned if your patient has a code yellow, this means that then the neutrophils are probably a bit low. You can continue clozapine, but you have to watch and you have to monitor more closely, so twice a week blood test to make sure that things are still okay. But just to keep in mind that this is a serious and important side effect of clozapine, especially in your patients at the end of life. Clozapine is tricky as well because if the medication is stopped for a few days, let's say because of a surgery or the patient is not collaborative because the patient is too confused for X reason, it's tricky because you cannot just resume the medication at the same dose it was, especially if it's been stopped for more than 72 hours. So here you have kind of a titration schedule. I don't think you're going to remember it, but just keep in mind clozapine, tricky medication, pharmacy and psychiatry probably should be involved, and you cannot just resume the medication as it was before if it was stopped for some time. So here we have a few questions. So if you have a patient on clozapine that has stopped smoking, and this is, I would say, quite frequent if a patient is admitted, or becomes too weak and cannot go out to smoke when they're hospitalized. What happens is that there's an interaction between clozapine and smoking. Smoking actually increases the metabolism of clozapine. So when they are admitted because they have stopped smoking, the clozapine level may actually increase, and patients may become toxic, very sedated. So think of that, and you can actually ask for a clozapine level. The thing is that that's going to take days, even weeks to get the level. So you ask for it, but you should decrease the dose, I would say, right away. And later you'll have your answer, like how high the clozapine level was. What should you do if you have a patient on clozapine that presents with fever or flu-like symptoms? You have to, as I said, keep in mind that clozapine can cause a reduction in white blood cells. So you have to make sure that this is not the case. So ask for a CBC. And clozapine can also cause myocarditis. Usually it's more in the first few weeks of treatments, or cardiomyopathy. So this is something to rule out and just not assume that this is like just a UTI or like a pneumonia, something I would say more easy to treat, less severe. Clozapine is also known to cause severe constipation, so don't assume that the patient is constipated because pretty much all patients at the end of life are constipated. It can lead to very serious events such as fecal impaction, bowel obstruction, and paralytic ileus, so keep that in mind as well. And as I mentioned, antipsychotics actually decrease the seizure threshold, but this is especially true with clozapine. This is actually the worst antipsychotic to decrease the seizure threshold. So we routinely add an anticonvulsant, especially when clozapine reach a certain dosage because it's dose dependent. So to add an anticonvulsant such as valproate or lamotrigine is something that we do on a regular basis. Mood stabilizers now. So mood stabilizers are used for the treatment of bipolar disorder, but they can also be used to augment antidepressant in the treatment of depressive disorders. The mood stabilizers that you can commonly see are lithium, valproate, lamotrigine as well. And it's really important, and what's important to remember is that you can actually dose those medication in the blood and have an idea if the medication is toxic or not, or if the patient is on a therapeutic dose. So if we start with lithium, so what you should do is actually to monitor the serum level. And the therapeutic range is different for an adult and an elderly. And I would also add for a frail, medically ill person as well. I would tend to use the elderly range for those patients, so between 0.4 and 0.8. The question is always, when should you actually check the level, the timing after the last dose? So we say usually it's between 6 and 12 hours post-dose, otherwise your level will be biased and you're not really going to have a true picture of how high or low the level is. But of course, if you suspect toxicity, you should ask for a level right away. Don't wait to be 6 or 12 hours post-dose. And of course, if your patient is going through a lot of medical treatments for their medical conditions, if they're not clinically stable, I would check the lithium level on a more frequent basis than just every 3 to 6 months when they are medically and psychiatrically stable. Important to keep in mind that lithium may actually alter the thyroid function, kidney function, and also PTH. Patients may have hyperparathyroidism when they are on lithium, so to monitor calcium. So calcium, it's not just because of bone mets, could be because of lithium as well. So another thing to keep in mind. And to assess for side effects and signs of toxicity. So here in the table you have signs of toxicity, of lithium toxicity. So yes, lithium can cause fine tremors, but really when you have a patient with coarse tremors, this is a red flag. Vomiting, diarrhea, so vomiting may not just be because of chemotherapy. Lethargy, ataxia, blurred vision, confusion, and even seizures. So I can see how tricky that could be for a patient at the end of life, because those symptoms could be attributed to the medical illness per se. We'll go over that a little quickly because I think that we were gonna run out of time. But keep in mind that lithium can actually increase white blood cells. So it's not necessarily an infection or because of steroid use. Also, in the context of renal impairment that you'll see in several patients at the end of life, it's important to monitor lithium to avoid toxicity. And also to avoid the use of NSAIDs, some antihypertensive medication as well, and diuretics, because that's going to cause an acute kidney injury and increase the lithium level as well. And nephrology should be involved, especially when the eGFR goes down to 30 or less. And of course, if the patient can no longer swallow pills, you call your best friend, the pharmacist, and you consult psychiatry, because lithium is a very special medication in the sense that bipolar patients that respond to lithium often do not respond to other type of mood stabilizers. So you really want to make sure that it's the right thing to do if you want to switch to a different mood stabilizers, given what's at stake. Patients with valproic acid, so same thing, you have to monitor the serum level. One thing that is very important at the end of life is that most patients will have low albumin, and valproic acid is tightly bound to albumin, so it's ideal to actually dose the free portion of valproic acid in the blood, because that's the fraction that is bioavailable. So even if your total valproic acid level is within normal limits, doesn't mean a thing, because you don't know if your free fraction is actually high or too high, and this may cause toxicity. Timing is pretty much the same as lithium. You dose 10 to 12 hours post-dose. In terms of monitoring, valproate can lead to hepatotoxicity, so liver function tests are important. CBC, although it depends. Some authors will say you have to screen routinely to check for low platelets. Other will say you're just going to monitor that if you see that your patient has a lot of bruising. But personally, I do monitor for that routinely. Also, keep in mind that even if the liver function tests are normal, patients may present with hyperammonia, which can lead to encephalopathy. So a patient on valproic acid with altered mental status, it's something to keep in mind and something that should be checked out. So I just mentioned altered mental status to rule out hyperammonia, rule out acute liver failure, or valproate toxicity. If a patient presents with hepatic impairment, again, you call your best friends and you consider an alternative treatment because valproate is mostly metabolized by the liver. Valproate can cause GI side effects, and when patients are really bothered by that, and we know that it's a common complaint towards the end of life, there's an enteric-coated formulation that can be used. And for patients that are unable to swallow pills, there's a liquid form that can be used, but there's no, let's say, sub-Q formulation. So again, psychiatry could be helpful in finding an alternative if it's needed. Next, lamotrigine. So this is a mood stabilizer that is way more easy to use in a certain way because there's not really like serum monitoring is not that used. One thing to keep in mind is that it can cause a skin rash. I would say 10% of patients will develop a benign skin rash. It's like the picture that you have, like the one at the top. But if you see that the rash is a bit more, like intense, covering like a bigger portion of the skin, if it starts especially like in the upper body, the trunk, or if it involves the mouth, the lips, this is a bit more tricky. And in that context, we would call that a medical emergency. So I would say ask for a dermatology consultation, and patient most likely will have to be hospitalized. But if it's just like a benign rash, you can just wait and prescribe like topical steroids for itching, and that would do the trick. So I mentioned it's dose dependent for nausea. So those can be decreased if it's an issue, and those should be decreased as well in the context of liver failure. Kidney impairment, it's a little tricky. Some authors will say, no, you don't need to modify the dose. Others will say, yes, you have to decrease by, let's say, 25%. So I would say it depends how clinically the patients present, but it could be reduced if the patient seems to be too sedated or a little bit slowed down. And one thing that is good to know is that it can actually help with pain control. I'm not saying that it's going to control all the pain, but it can be an adjunct. So why not, when it's on board? Antidepressants now. So a patient on antidepressants, again, why is that patient on antidepressants? Is it because there's a history of treatment refractory or severe depressive episodes or very severe anxiety? I would say, as a rule of thumb, sertraline, citalopram, escitalopram, and desvenlafaxine are good antidepressants in the sense that they are well tolerated and they cause very few drug-drug interactions, especially in the medically ill patients. However, others should be avoided, such as fluoxetine, paroxetine, fluvoxamine, tricyclics, and MAOIs. Fluoxetine, the reason is because it has a very long half-life, so it may accumulate in patients. And paroxetines and tricyclics, they actually have anticholinergic properties. So if you want to avoid all the side effects, confusion, constipation, etc., try to stay away from these. And they cause a lot of drug-drug interactions as well. So if you have a patient on antidepressants, or if you have to choose an antidepressant, I would try to pick one that can actually have a benefit for other symptoms. Like duloxetine may help with neuropathic pain. Hot flashes may be controlled with sertraline, venlafaxine. Mirtazapine may help with nausea. anorexia. I think most people practicing in palliative care know that mirtazapine can increase appetite, but it can also help with pruritus. And I have to say, I was not aware of that. I discovered that doing my review for that presentation, but that could be interesting. And bupropion can actually be used for fatigue. Theoretically, it's an activating antidepressant, but personally, I have to say, for some patients, it's not that activating, but in theory, it is. In terms of side effect profile, just to name a few, I think most of those that are listed on the slide are relevant to palliative care, but keep in mind that SSRIs can cause GI bleed. So if you also have a patient on steroids, that could be, or NSAIDs, that could be an issue. QTC prolongation, especially with citalopram. Bupropion can actually lead to seizures. So if you have a patient on that, on an antipsychotic, and let's say with electrolytes imbalance, that can lead to seizures. So something to watch for. And also, your best friends, the pharmacist and a psychiatrist, can help you when you have to switch, to a formulation that is not PO. I'm pretty sure that's what you're going to remember from that presentation. Pharmacy and psychiatry, yeah, don't hesitate and ask for their help. In terms of sedatives, if you have a patient who's been on sedatives for a long time, then you have to weigh what are the risks and what are the benefits of keeping those medications. There are several risks that are pretty significant. And I would say you have to assess what are the goals of care, and if the patient prefers to keep their benzo or their trazodone for sleep, despite the fact that it causes orthostatic hypotension and falls, that's fine as long as you have an open discussion with patients. But they can be very helpful. Usually they help with anxiety and insomnia right away. Benzodiazepines are really helpful with nausea and vomiting, especially before chemotherapy. I would say, as a rule of thumb, you use the lowest effective dose, and you prefer meds that are not metabolized by CYP, but more by phase 2 metabolism. So the acronym is LOT, lorazepam, oxazepam, and temazepam. Those doesn't tend to accumulate in patients with liver impairment. And you try to avoid, especially I would say benzos with very short half-life, such as alprazolam, because that's going to cause withdrawal symptoms. And also drugs that tend to accumulate in body fat, such as bromazepam, because again, patients will tend to present with toxicity and side effects. Let's move to objective 2. So identify prescription strategies for tapers and increases for common psychotropic medications. So it's more like you have a patient and you want to start something. So how can you adjust the dose? So in general, I would say for those who are naive, frail, or older, you start low, you go slow, but you keep going, in the sense that you want to reach a therapeutic dose to make sure that you did an optimal trial of that medication. For those who's been chronic users of psychiatric medications, like your 55-year-old schizophrenic patients, who's on let's say 3 antipsychotics, an antidepressant, and a mood stabilizer, and they are delirious, you're like, what do I do with the antipsychotics? I add one, I increase the dose, what do I do? So it's possible that they're going to require high dose, or that you'll have to add maybe something to potentiate the effect of the meds that are already on board. And if you increase or decrease doses, I mentioned be patient, because psychotropics, it takes some time to see the effect. I would say for side effects, in a few days or weeks, you'll have an idea if what are the side effects and if they're going to disappear with time. But for signs of decompensation, it's more like weeks to months. So you can say, I stopped this patient antipsychotic, but he's fine. He's not psychotic. But let's wait. Maybe in 3 months, that's going to be a different story. So clinical pearls for antipsychotic, as you probably know, it's used as a first-line treatment for delirium. You probably think of haloperidol when you think of delirium, but there are alternatives that can be used as well. I mentioned at the end methotrexate because especially for terminal delirium, it can be used as a palliative sedation for for hyperactive delirium, that is when patients are pretty agitated. And a bit like with the antidepressants, try to kill two birds with one stone. So what can you do with one medication? So haloperidol can help with nausea. But here I mentioned that the dose range. You may be more familiar with, haloperidol at low doses, but if a patient is quite psychotic, used to antipsychotic medication and delirious, you may bump up the dose without being too fearful. Olanzapine, used for nausea, but you can bump up the dose too if you want to use it as an antipsychotic. And quetiapine you probably use at a low dose to help for sleep. But quetiapine is an interesting medication in a sense that depending on the dose, it has a different indication. So between, I would say, 50 to 300 milligrams, it acts as an antidepressant. So if your patient is depressed and you already have quetiapine for sleep, instead of adding something else, you could actually increase the dose and see if your patient's going to respond to that. And if you keep increasing, you're going to reach an antipsychotic dose, so between 400 and 800. So for those of you who are used to prescribe quetiapine 25, quetiapine 400, 600, really? Yeah. But if you're not comfortable, as I said, you call your best friends and they're going to help you with that. One thing that is important to know is that antipsychotics, the dose can be divided. So when it's given BID or TID, it's the tolerance that is better. So for an example, patients with orthostatic hypotension, instead of giving risperidone 2 at bedtime, you can split 1 in the morning and 1 at bedtime, and it can do the trick. So patients won't be dizzy anymore. So for antidepressants now, and I'm assuming this is something probably that you have to do in your practice. So you have a depressed patient, you want to start an antidepressant. So you start at the lowest possible dose, I would say. Let's take one, for example, sertraline. So you would start your patient on sertraline 25 for a week. Sertraline 25, you don't expect your patient to do better on it. It's sub-therapeutic, but you just want the body to get used to the medication, so to avoid side effects. After a week, you increase to a therapeutic dose, let's say sertraline 50. And then you wait. What you want to do is actually an optimal therapeutic trial. So you wait, but for how long? So usually we say you wait for 2 to 4 weeks. If after 2 to 4 weeks, the patient has no response at all, you increase the dose. And you reassess 2 to 4 weeks after. However, if after 2 to 4 weeks, the patient says, well, I think I have a partial response. I sleep a little better. I'm a little less anxious. I have a bit more energy. So you wait. You don't increase the dose. Antidepressants, they take a long time to kick in. So you wait. And we can wait till like 6 to 8 weeks, and then you reassess to see, okay, have we reached a plateau now? Should we keep increasing, or maybe actually we found the right dose for the patient? So of course, this is, I would say, an avenue that you can use when your patient doesn't have a very poor prognosis. Okay? If you don't have weeks or months in front of you, this is not a good option. And we'll talk about something different. And my colleague after me probably is going to talk about something else that could be interesting for those patients with a very limited prognosis. Then the question is, okay, we actually were at sertraline 100. The patient does not really respond. What should I keep increasing, or should I just augment with another agent? So we say that you switch if the patient doesn't tolerate the medication. Let's say sertraline 100, no response, but like terrible nausea, then you could switch. If the patient hasn't tried many antidepressants before, you have other options. It's very reasonable to switch. And as I mentioned, if the patient has, let's say, a prognosis of several months, that's reasonable. However, you may consider to augment with an adjunct medication if the patient has reached, let's say, sertraline 200, which is the maximum recommended dose, tolerates the medication well, has a limited prognosis. You don't want to wait and start again with a new medication. So you're going to just add something. The effect's going to be faster. So here you have what are the first line, second line, and third line. I think, let's say, olanzapine, although it's a second line, if it's already on board for nausea, maybe you can just like increase the dose and see if it helps. Same thing, methylphenidate is a third line, but it can be helpful for opioid-induced sedation. So if it's already on board, maybe, take advantage of those meds. Other thing to keep in mind, antidepressants, especially paroxetine and venlafaxine, they may cause discontinuation syndrome. So they can be very hard to discontinue. Patients will feel unwell. They may have flu-like symptoms, like paresthesia, like electric shock type sensations that may last for a few days or weeks. QTC prolongation is something to keep in mind with citalopram and escitalopram. So there are specific doses that are recommended in the elderly and patients with liver impairment. One thing, mirtazapine is often used by my colleagues in other specialties because of the sedative effect. But one thing to know is that mirtazapine, as you increase the dose, you lose that sedative effect. So we say around 15 and over, the sedative effect is not there anymore. And also there's some tolerance. After a few days or weeks, even if you use mirtazapine 7.5, this sedative effect won't be there anymore. So keep that in mind. It's more like a short-term alternative for insomnia. And then if you use TCAs, don't forget that you can actually dose them, have a blood level. In terms of sedatives now, if you want to taper or discontinue, especially benzodiazepines or Z drugs, as an outpatient, it's usually, personally, I prefer just to taper by 10% monthly. You're going to say that's nothing, 10%, but if you want to make sure that the patient's going to tolerate the whole withdrawal process, I would say that's safer. Sometimes you cannot because the formulations, the dose that are available for the different tablets, you cannot do that, but I would say you try to, decrease by the smallest dose possible. And that's going to be, of course, a long process. And if patients really has withdrawal symptoms that are bothersome, switch to a longer-acting benzo, such as clonazepam and diazepam. Although they are not I would say, palliative care friendly in the sense that they're not metabolized by, I mentioned the phase 2 metabolism by the liver, but if you have a real indication, I think that's very reasonable. And here I mentioned my personal preference in terms of hypnotics. What I think would cause least side effects would be more reasonable. But of course, sometimes if you start with melatonin, patients will still have problems falling asleep, or you have to switch, to something different. But I know quetiapine is extremely popular, but quetiapine has some anticholinergic properties. Quetiapine can cause orthostatic hypotension. So that's why this is not my first option. Lamborexin is interesting in a sense that it doesn't really have cognitive side effects. It's not addictive. It's usually well tolerated. So that's why it's my second option. And at the end, you have doxepine because it's anticholinergic, and you try to avoid that in your end-of-life patients. So this is for your personal reference. Let's move on to psychostimulants. So in palliative care, it's used for hypoactive delirium to improve attention and alertness. Also for depressive symptoms. And here I mention symptoms and not necessarily depression, because the evidence are, we don't have a randomized controlled trial with psychostimulants at, in a palliative care population, but it may help with mood and fatigue and appetite and concentration. But don't expect to really treat your patient's depression with psychostimulants. But it's, of course, a very interesting option when someone has a very poor prognosis. And although it's controversial depending on the references, if you have to adjust in context of kidney or liver impairment, but it's an interesting option. Just keep in mind that it can has side effects such as anxiety, agitation, psychotic symptoms, and also has some cardiovascular symptoms. So depending on your patient, it may not be a good option. But it is an option. So here you have a few, usually we say start at a low dose. Like I would personally start at 2.5 for methylphenidate if I have a very frail patient. If it's well tolerated the day after, I would give 2.5 morning and lunch. Of course, you don't want to give it at the end of the day because it may cause insomnia. Anyway, you want your patient to be more activated during the day, not at night. Modafinil is another option. And I would say it's easier to titrate the dose. However, one thing important to mention, do not use the extended release form. It's really like methylphenidate immediate release that you use. But unfortunately, it's only used, unless I'm wrong, I should ask my friend, my pharmacist friend, but I think it's just available as a PO formulation. So if you want to use it for your patients that have a short prognosis for depressive symptoms, if they cannot swallow, that can be tricky. Last objective now. To recognize medication interactions between psychotropic medications and common medications used in palliative care contexts. So here, probably I could have added like slides and slides, but it depends really what type of patients you treat, if they are early in the illness trajectory, still receiving chemo or radiation therapy, or but here you have a few examples of, I would say, pharmacodynamic interactions. So QTC prolongation, it happens with citalopram, antipsychotics, also with lithium. If you have a patient on methadone or on certain type of chemotherapy, something to watch for. So you try to avoid combination of those meds if possible. If you have to use an antipsychotic, I would say prefer the newer generation antipsychotics such as aripiprazole, lorazepam, because they don't really have that QTC prolongation effect. Myelosuppression, I mentioned earlier, clozapine can cause that, so it's not a good combo with chemotherapy, radiation therapy. So if it has to happen, well, just monitor CBC more frequently to make sure nothing severe happens. GI bleeds, I briefly mentioned, so SSRIs, SNRIs, when used with NSAIDs or steroids, they can cause GI bleeds. Hyperglycemia, I mentioned as well, so your antipsychotics and your steroids. Hyponatremia, so let's say SSRIs, especially when you initiate treatment or when you increase the dose, we say like after a month, it's good to control for your sodium level. But if you have a patient on diuretics, specific chemotherapy agents, it may cause an SIADH as well, so monitor your sodium level. And serotonin syndrome, although we always talk about that, personally, I don't think it's that frequent, but so pretty much all the antidepressants, lithium, and opioids, they can lead to a serotonin syndrome. Also, some medications that can be used in a palliative care context, such as ondansetron, metoclopramide. So you try to avoid concomitant use. In terms of pharmacokinetic interactions, I had a hard time to decide which tables I would show you. I would say if you have to remember something, the psychotropics that tends to cause less drug-drug interactions are citalopram, escitalopram, desvenlafaxine, mirtazapine, and venlafaxine. For the antipsychotics, we mentioned paliperidone because it's actually excreted by the kidney. So that's why we don't really worry about drug-drug interactions. The drugs that you don't want to use are actually those at the bottom of the slide, such as fluoxetine. Actually, I mentioned it has a long half-life anyway. You don't want to use it. Fluvoxamine, it's rarely used. It may be used in combination with clozapine, but I don't think you're going to see much patient on that. Paroxetine, however, you can see frequently and you try to avoid because of the anticholinergic side effects and because it's a strong 2D6 inhibitors. And in terms of antipsychotics, so clozapine, quetiapine, and lorazepam, they tend to cause more drug-drug interactions, so you try to avoid. And here you have, like, I picked a few chemotherapy agents. To be fully honest, I'm not even sure they are that often used. This is really not my expertise. Of course, we all know about tamoxifen, that you should avoid 2D6 inhibitors. But for the others, I would say depending on your population, as I mentioned, you know which psychotropics should be avoided. So if you have such psychotropics on board, maybe check with the pharmacist if there's an interaction with the different chemotherapy agents. But this is, I would say, patient dependent. So we're gonna end on that. So in a nutshell, when you treat a patient who's known for chronic psychotropic use, you don't modify treatment without thoughtful considerations, and you involve your best friends, pharmacy and psychiatry. And when you prescribe psychotropics in palliative care, be mindful of the dual effects. If you can kill two birds with one stone, to avoid polypharmacy, and always think of the different interactions. So here you have the three main references I used. I'm here if you have any questions.
Thank you very much. Thank you very much. Unfortunately, we run a bit over, so I will have one question, which is from the online. So the question, I would aggregate two questions. So what are your thoughts about the use on antipsychotic at the very end of life and their last few hours, and how we can regarding the seizure threshold and the possibility that it is akathisia that we're seeing?
Okay. What do I think about the use of antipsychotics towards the very end of life? I don't know what this person is referring to. Maybe the use of methotrexate, which is used often, for very agitated terminal delirium, used as palliative sedation. I'm actually not against it. I don't know if they wonder if patients may be more agitated at the end of life because of antipsychotics, if it's akathisia. Akathisia, some antipsychotics are more prone to cause akathisia, such as aripiprazole. I don't know if I'm going to be able to answer that question. It is a possibility. So if it's akathisia, you reduce the dose or you stop the medication, and if the agitation resolves, then you have your answer. But if it's not the case, then there's another explanation. I'm sorry, I'm not sure I answered properly the question.
If I may add also, if you are thinking about akathisia, you can always think about the midazolam, which is a treatment for akathisia. And also, if you are afraid of any seizure, then midazolam is also a seizure medication. So it's just also if I complement your answer. Thank you very much for your answer and your presentation. Thank you.